the cloud. Perfect. All right. Hello, everyone, and welcome to the Monday session, session two. Um, this is our first day that we're doing our drugs. So it's a really exciting day. I like to think of pharmacology as the day you finally get to do real pharmacy stuff, and this is where we start to introduce some of that. Just as a reminder for everyone, too, uh, if you go to tinyurl.com/Gabe tutoring, so who I am and what I do, it will bring you to a Google Drive link. And then uh, in the fourth year tab, you can use semester 1 and 2 to go through all my old notes. It's everything that um, it's everything that I took when I was a student there. So if you ever want to go and see, oh, how did Gabe prepare for this? That's where that is. Biotech, everything's in there. Um, Take it with a grain of salt. The biggest thing that you'll probably take away from this is when in the spring semester you're going to take virology. Um, and oh boy, did I put way too much effort into virology. Um, Virology combines pharmacology, medchem, and therapeutics into one class, and it's as much work as taking 3 classes as one. So that's a lot of fun. Um, so enjoy it. God. But anyways, without further ado, let's talk about pharmacology. All right. Um, Big thing to know about this PowerPoint when we go through it is that we're going to be focusing on a system called the red light, green light, yellow light, red light. Um, Green light is what you guys should know from pathology, or it's just above the pathology kind of understanding. So if you can really hone in and almost be able to spit out green light information like right away, then you're in a really, really good place for that topic. If not, go and review it, or obviously, we're going to talk about it a little. Yellow light is what I consider new information. So it would be anything that we talk about that's pretty much pharmacology related. And then red light is we're going to dive down a little bit deeper into some of the more specific topics. But these are things that I'm generally not going to spend a lot of time on because that's something that really should be more discussed when you're in the course. Dr. Keel is way more qualified to teach you that information, in my opinion. But if there's something that I feel comfortable I can talk about, and that it's not overly difficult, then we'll give it a crack. Um, the Before we get started, and we really talk about everything, this entire PowerPoint is about the nervous system and how we can use drugs to affect the nervous system. And there's different areas of the nervous system that we can affect. But in general, I wanted to start off and talk about some drugs that affect nerve transmission. And with that in mind, we can kind of review very quickly the CNS and its different places. By the way, if I'm going too fast in the chat, let me know. Obviously, we know we have the somatic motor pathway, we have the somatic nervous system and the autonomic nervous system, and the somatic nervous system is uh, the one that we can control on our skeletal muscle, and the autonomic is something we cannot. What's important to note for pharmacology is the different kinds of receptors that are down here. And this is something that you should remember from pathology, is that we can have nicotinic receptors, which have acetylcholine, um, acetylcholine being the neurotransmitter. Again, we can have that nicotinic receptor. We can also have muscarinic receptors, which are uh, also have acetylcholine as their neurotransmitter. But if you notice that the nicotinic receptor is always preganglionic, all right, that we're going to find nicotinic almost entirely within the CNS. And then, of course, we're going to have some skeletal muscle nicotinic receptors. But what I want you to keep in mind is that this nicotinic receptor that's part of the somatic pathway is completely different structurally than the ones found in the autonomic. So when we eventually talk about drugs that affect nicotinic receptors, we're not really going to be talking about them as equals. The somatic pathway is different from the autonomic. Likewise, you can have postganglionic nerves that release norepinephrine, and uh, those neurons are going to innervate adrenergic receptors. And that's what this word here is, adrenergic. Likewise, the adrenal pathway is responsible for releasing epinephrine, which is released from the adrenal medulla. And this uh, hormone, as it is released and travels through the blood vessel, where it can affect the same adrenergic receptors. So what we're going to find later on is that norepinephrine and epinephrine affect the same receptors. They all have some sort of effect on our alpha and our beta receptors. And what's really important to note is that each one of these pathways has different effects. We remember that the parasympathetic pathway is more of rest and digest. The sympathetic pathway is more of our fight or flight response. Likewise, it's important to note that the sympathetic pathway starts at the thoracic lumbar regions of the spine, and the parasympathetic is the cranial circular regions. Uh, and then again, the cholinergic neurons are the ones releasing this acetylcholine. Cool. This should be big review, just some good pictures to kind of remind you of pathology.
Can you
Another
actually
picture.
repeat what you said for parasympathetic and sympathetic pathways, choronic? That whatever you said.
Uh, cholinergic, yeah. So cholinergic is a word that describes any neuron that transmits acetylcholine. So these nerves here, these ones that release this acetylcholine, can be considered cholinergic.
Thank
Likewise,
you.
these ones
Hmm.
up here and this one here. Another picture for you, just showing again in a different way the different kinds of nerves where we are, our preganglionic neuron or ganglia effector neurotransmitter in the target organ. What I want you to take a note here is that if you notice cardiac and smooth muscle, gland cells, sweat gland cells, nerve terminals, what you can see is that the sympathetic nervous system and the parasympathetic nervous system innervate the same areas in the body. And that should make sense, right? That if you only had one innervating one area, then you constantly be in fight or flight, or you constantly be in rest or digest. So what we call this is dual innervation. And this idea of dual innervation is really big because, in general, most of the time, the effects of the sympathetic and the parasympathetic nervous system are going to be opposites of each other. But with that in mind, we can kind of set them up as antagonists to each other as we can kind of consider them. Although we won't really get to the sympathetic nervous system for a little while. We'll talk almost exclusively about the parasympathetic. All right, let's dive into some pharmacology, shall we? What we see here is a neuron that ultimately releases acetylcholine. So, this cholinergic neuron synthesizes acetylcholine within inside of its nerve terminal. And what's important to know is the different avenues in which it happens. And what we're going to find is that there are certain drugs that affect this pathway of nerve transmission. Because this release of acetylcholine is the only way that our body can have one nerve communicate with the next nerve. If nothing is released, then nothing can be talked about. And what I want you to note is that when acetylcholine is synthesized inside the nerve terminal, it's taken up by this VAT transporter, this vesicular acetylcholine transporter. And the reason why that's important is because nerve neurotransmitters that are inside the nerve terminal are not safe. They're likely to be broken down by different enzymes within the nerve terminus. And so we have to store our neurotransmitters within a vesicle in order to protect them from any kind of enzyme that might be out there, like acetylcholinesterase, or there might be something else that affects our acetylcholine. What's also important to know is that inside those vesicles could also be ATP, could be phosphate, could be other co-transmitters that are also released at the same time. But really, what we care about is this vesicular acetylcholine transporter. What's also important to remember is last time we met, we talked about how when the action potential comes down the nerve, it stimulates the nerve terminus and it opens these voltage gated ion channels, which allow calcium to come into the cell, which stimulates this vesicle to move towards the membrane. And what I want to tell you this time is that what helps the vesicle fuse to the membrane are these VAMP proteins and these SNAP proteins. And the SNAPs and VAMPs, what they do is they kind of act like Velcro and help the VAMPs, which are on the vesicle, vesicular amino proteins, I can't remember the full name, and the SNAPs, which are on the membrane, help stick it together. And that's the big thing to know here is that via this velcroing of the SNAPs and VAMPs, we are able to fuse the vesicle to the cell wall and eventually release their acetylcholine. This acetylcholine then travels across the synapse where it can affect these cholinesterase and where it would be broken down by acetylcholinesterase, which would then terminate the nerve response. As we move on to a different kind of receptor, one that is incredibly similar but releases a different product, is this one is a adrenergic receptor because it's releasing this norepinephrine. And it's really here that we're going to focus on this production of norepinephrine because its pathway is really indicative of a lot of different drugs we can use in order to mitigate norepinephrine release. The pathway is that do I have it on the next slide? Yeah. That tyrosine, can I draw on this? No, I can't, but I have a laser pointer now. Tyrosine is taken up into the nerve terminus, where this tyrosine is converted to dopa, L-dopa, via tyrosine hydroxylase. So let me actually draw this out for us. Boom, boom. There we go. First, what happens is the tyrosine is taken up into the cell, and that tyrosine is converted into L-dopa via tyrosine hydroxylase. L-dopa is then converted into dopamine via an enzyme that's called AAADC. Aromatic, I had it written down. I think I have it in here. Do I have this written out? I do. This enzyme is also more referred to as dopa decarboxylase. I think this is aromatic amino acid decarboxylase, is what AAADC stands for. But you'll see a lot of the time dopa decarboxylase. Now, this is all happening within inside the nerve terminus. This is within the cytoplasm. So, what then has to happen is that this is taken up into a vesicle. And it's taken up through a transporter, just like we saw with this acetylcholine, because remember that neurotransmitters are not safe within inside the nerve terminus. There's plenty of enzymes that would likely break this down. And one of the big enzymes that would break down dopamine or norepinephrine, um, really a lot of the different uh, hormones or neurotransmitters, is the MAO enzyme, the monoamine oxidase. And we don't particularly care about what they turn into, but know that they're no longer neurotransmitters that can conduct our nerve transmission. So MAO breaks apart our monoamines and prevents them from having our nerve transmit what signal it's trying to say. Whether that's, histamine, dopamine, norepinephrine, whatever it is. So our dopamine has now been taken up into the cell. And dopamine is converted into norepinephrine inside the vesicle. And it's done on an enzyme called dopamine beta hydroxylase. And now this norepinephrine is safely stored in our vesicle, waiting for the nerve stimulus to come in, which will send, influx of calcium, which will send the vesicle to fuse to the membrane using our snaps and vamps, and then release the norepinephrine. Now, as well, our enzyme or our nerve could release dopamine depending on different pathways. It can produce different means depending on what kind of neuron it is. But in general, this is the pathway that produces norepinephrine. And of course, too, there might be other co-transmitters like ATP, there could be NPY, other transmitters that we don't particularly care about, but they might be, within the same vesicle that the norepinephrine is stored with. And so if we go back to our picture, what we can see again is that this dopamine is taken up through a transporter called VMAT, which is the vesicular monoamine transporter. And what I want you guys to put a star next to this VMAT, because he's going to come back later, uh, very soon, really. And we're going to talk a little bit more about VMAT inhibitors and what the effect of inhibiting VMAT must be. There are other, just like with acetylcholine, the biggest thing that terminates the nerve transmission with acetylcholine is this acetylcholinesterase, which breaks down the acetylcholine into the two components. Oop. Could you allow access to the PowerPoint? Do you mean into? Oh, I see what I did. Whoops. There you go. That should be all set for you guys now. My bad. Is that in there? Perfect. Just to repeat what I just said, put that star next to the VMAT inhibitor because we're going to talk about him again in a second. Just like with acetylcholine's nerve transmission can be terminated via that acetylcholinesterase enzyme, which is in the synapse. And that's the main way that acetylcholine is broken down is through this enzyme, which breaks it down into its choline and acetate components. And this nerve transmission is pretty quick, right? We're talking about a super, super quick clearance of acetylcholine. If we didn't clear it very quickly, then we'd have a pretty sustained nerve transmission. Same thing with norepinephrine, except that it's not directly broken down. It's really going to be reuptake into the presynaptic neuron through this norepinephrine transporter. And the other primary way that norepinephrine is terminated is through just gentle diffusion away from the synapse. So two ways that norepinephrine nerve transmission is terminated. One is by reuptake into the presynaptic neuron, and the second is through general diffusion away from the synapse. Now, you might have noticed in these diagrams, you see all these different drugs. Here's hemicolanemus, vasimicol. We have maybe some drugs you recognize like reserpine or the tricyclic antidepressants. Eventually, we'll talk about all of these. Some of them we won't because they weren't covered in the course, but you can see where their effect would happen. And pharmacology is all about those mechanisms of action. And without further ado, let's talk about our first drug. Now, what's important to know is these words up here, indirect and sympathomimetic. And what we're going to see in the next couple of slides is a slightly different word, but sympatholytic. And we'll talk about it when we get there. But this word indirect means that we're not affecting these receptors on the postsynaptic neuron. All right? We are affecting the neurons that are presynaptically. So somehow we are affecting the neurotransmitter transmission in a way where we are not directly blocking or agonizing these receptors. The other big word here is sympathomimetic. And what mimetic is something that's mimetic means that it copies or that it's the same as. So what this is saying is that these drugs mimic the sympathetic nervous system. Now you might be thinking, well, wouldn't these just be agonists? No, they're not agonists because they're not directly affecting those postsynaptic neurons. These drugs are going to be affecting the presynapse. So we can't call it an agonist because it's not directly affecting what the sympathetic nervous system's target would be. So it's mimicking the sympathetic nervous system, but it's not directly acting the same. And once again, that combines with this term of indirect. Our first drug that we're going to talk about here is Botox, which was kind of interesting to me going through the course, that the first thing that we would talk about is something that I felt like I knew a lot about, but truly I knew almost nothing. Botox is a toxin from the botulinum bacteria. And what the botulinum toxin does is that it breaks down and targets the SNAP25 protein. And what we can think about is that what happens if you cleave this SNAP25 protein, what's its downstream effect going to be? We have the cause, we're cleaving it, and the effect means that our vesicle can no longer fuse to the synaptic cleft. it can no longer release our acetylcholine. Now, what that means is that if we can't release our acetylcholine, then we can't transmit our cholinergic response, and we're going to be affecting our nicotinic membrane, our nicotinic neurons, our nicotinic receptors. And what this ultimately means is that we're going to be preventing skeletal muscle from being controlled. And because we're mimicking the sympathetic nervous system, if you increase the sympathetic nervous system stimulus, then we're going to be decreasing the parasympathetic input. Because you can't have both at the same time. It's like a scale, right? And if the parasympathetic nervous system is all about rest and digest, don't move a muscle, relax, it's okay, then the sympathetic nervous system is all about, okay, let's get going. All right. And if you're blocking the sympathetic nervous system, right, if you're causing it not to being able to fire because we're blocking this ability for it to come together, then ultimately what's going to happen is we're going to be decreasing this nerve input on skeletal muscle. And so our uses here are going to be all different effects of uh, overstimulation in the muscles. So we have things like the blepharospasm, which is eyelid spasms. It's where you're blinking way, way too much. You have the strabismus, which is where your eye muscles are pulling your eyes to be cross-eyed. You have certain kinds of migraines are caused by your muscles pulling so tightly that you're getting a migraine. So it's migraines due to muscle contraction. You also have cervical dystonia, which is where you have such strong neck contractions in those muscles that you can't turn your head. It hurts a lot. And then just to go back to, those were all pathways of blocking this acetylcholine release on the somatic pathway. And what we're going to see is that we're also going to be blocking this parasympathetic input, right? Because, sorry, not here. Here, we're going to be blocking this input. So that means we're going to be decreasing this sympathetic parasympathetic pathway. And so what effects are we going to get from decreasing the parasympathetic input? Well, we're going to decrease sweating. We're going to prevent an overactive bladder. And those are the major effects of Botox, is we're going to be stopping nerve transmission in the somatic pathway, and we're going to be stopping nerve transmission in the parasympathetic pathway. Two big effects. What's important to know about Botox is that it's reversible after 3 months. So eventually your nerve cells will regenerate these SNAP proteins and allow for the vesicle to refuse to the cell membrane, allowing for better acetylcholine release. And because of that, if you want to continuously block that effect, you have to keep getting Botox, keep getting Botox. And for some of these, like the blepharospasm or the cervical dystonia, it can, it's a lot. And these are local injections into specific sites in the muscles or into the sweat glands. So it can be a lot to handle. One thing to note about these SNAP proteins is that once again, you'll see that there's lots of different types of Botox, but in general, we're going to lump them together because as you can see, this specific one affects the SNAP25. There's also Botox that affect another kind of helper protein, syntaxin. And then we have, obviously some Botox that affect VAMPs. But in general, we're going to lump them together and say they affect the SNAP25. And again, we're preventing uh, that Velcro from happening. The question becomes, well, don't adrenergic, don't these nerves that release the norepinephrine, don't they also have snaps and vamps? Well, of course they do. But remember that these are two different kinds of nerves, and they're in two different parts of the nervous system. One's in the parasympathetic, one's in the sympathetic. All right. And even though, like I said, they're both nicotinic receptors, they're both cholinergic neurons, but they're completely different from each other. So they're going to have different snaps and vamps. Now, there are uh, drugs that affect the snaps and vamps for these neurons, the ones that release the norepinephrine, but we're not going to be focusing on those in this course. So the only one we really care about right now is the Botox. Any questions so far about Botox? Cool. All right. Going back into our neurons that release the norepinephrine, uh, what's important to know here is that we're going to be affecting the pathway releasing norepinephrine. And there's two different ways that we can affect that pathway. We can either increase the output of norepinephrine or we can decrease the output of norepinephrine. And because we're going to be talking about this presynaptic neuron, what I want you to ignore is everything that comes after the norepinephrine release. We'll talk about that later as we go through the PowerPoint, but I want to focus on what we talked about as we drew out the steps of norepinephrine synthesis. Our next drug that we're going to talk about is droxidopa, brand name Northera. And droxidopa is a substrate for that aromatic amino acid decarboxylase that dopa decarboxylase. And so, let me make sure I'm coming to the right place. Can you guys see this? Hopefully, can you see the drawing screen? And so, because droxidopa comes in at this stage, here's droxidopa. Zoop, comes in. By adding droxidopa, what's going to happen to the levels of dopamine? Well, we're going to have more of it, right? If we're giving more starting product, the enzyme doesn't care as long as it can work on it, and we're going to be converting more droxidopa into dopamine. If we have more dopamine, then we're going to shunt it into the vesicle, which is then going to cause more norepinephrine to be created. So by administering droxidopa, we are increasing the amount of norepinephrine that the nerve would make. And so, whoops, I clicked the wrong button. And so what's important to note here is that overall, our biggest effect is increasing the amount of norepinephrine. And that's going to have two major consequences. The first is that it's going to affect that cardiac muscle, and we're going to increase the stimulation on the SA node. And that stimulation is going to cause the heart to beat faster. And which will increase the blood pressure, right? Because we know that cardiac output is a mechanism of blood pressure and heart rate. Cardiac output is also going to increase because we're going to be stimulating the smooth muscle surrounding the blood vessels. And what that's going to do is it's going to stimulate them to decrease in size. They're going to decrease their diameter. And again, what's the overall effect? That's going to be an increase in blood pressure. So two effects: increase heart rate, increase blood pressure.
I have one question. Then, is it related to the increasing sympathetic nervous system, or is it decreasing?
Um, what would be increasing? What's related? Sorry.
Oh, I meant by is the sympathetic nervous system is going to increase
Yes.
or
So the
hmm
effect of the sympathetic nervous system would increase. Yep. And we can think about this too, right? Because what does the sympathetic nervous system does? It's fight or flight. And what does your heart do while it's fighting and flighting? It beats faster and your blood pressure increases. So we're having a bigger sympathetic effect. It's mimicking that sympathetic nervous system. But how's it doing it? It's doing it indirectly by affecting the presynaptic neuron instead of the postsynaptic neuron. The big use for droxidopa is orthostatic hypotension, which is when you stand up and your blood pressure drops, which causes you to get dizzy. You can, fall, hit your head, you can pass out. So this could be pretty dangerous, especially for older people. So this droxidopa is a good way of kind of nudging the body to have a little bit better blood pressure, a little keeping the heart rate pumping a little bit better. Our next set of drugs that we're going to be talking about, hopefully you guys can see the PowerPoint, right? Give me like a thumbs up somewhere. Can we even do that? No, I think that's Blackboard. I'm going to assume you can see it. The next, okay, cool. The next kind of drugs is what we're going to describe as indirect sympatholytics. Now, we know the word indirect means that we're going to be affecting that uh, presynaptic neuron, but sympatholytic refers to this idea of blocking or preventing. So, with this in mind, what we can assume is that we are going to be somehow preventing the whoops, this is wrong word. My bad. Cross that out on your if you printed it out. We're going to be preventing the we're going to be preventing the sympathetic nervous system stimulation. These drugs are referred to as VMAT inhibitors, and that should hint to you what these drugs are doing. If we go back to our diagram, what we know is that these drugs are going to be preventing dopamine from entering into the vesicle. And so what this means is that more dopamine is going to be staying outside the vesicle, which is going to be attacked by MAO. And this is going to decrease the amount of dopamine available for nerve transmission. This is also going to downstream affect the amount of norepinephrine that can be released. And so we're going to be decreasing our sympathetic nervous system stimulation, which means that we're going to be acting as a sympatholytic. We're going to be blocking the sympathetic nervous system stimulation. We have 4 drugs that do this: reserpine, valbenazine, tetrabenazine, deutetrabenazine. And the biggest effect is preventing that norepinephrine release. So just like how we saw with increasing norepinephrine, decreasing norepinephrine is going to have the opposite effects. Whoops, this should be decrease. Ha ha ha. We're going to be decreasing that cardiac muscle stimulation, which is going to decrease the stimulation on the SA node, which effectively has a decrease on the heart rate and the blood pressure. The other effect is on the smooth muscle, which is going to increase the blood vessel diameter, which is in effect going to decrease the blood pressure. So overall, we're going to be lowering the blood pressure, which is why these drugs are used for hypertension. They're not really first line treatments anymore. They're really more, these are much older drugs, but they are a potential use. What's important to know is that reserpine is an irreversible inhibitor of VMAT. Now, just like what we saw with Botox, Botox also is irreversible, but uh, sorry, let me put it this way. Even though that this drug is irreversible, our body will regenerate uh, that VMAT transporter eventually. It's not going to disable it, and then suddenly we have no norepinephrine release ever. Eventually, those vesicles are going to be recycled, and the VMAT inhibitor is going to come back. And so, even though reserpine is irreversible, it doesn't mean it has a infinite effect. But how does this affect the duration of action of the drug? Are we going to have a very short duration of action, or are we going to have a very long duration of action? And the answer is we're going to have a long duration of action because it's going to take a while for that nerve to regenerate the VMAT transporter. It's, might take a couple weeks, something like that. But by continuously taking the reserpine, we're going to be continuously preventing that VMAT inhibitor. We're not going to prevent all of them, or else, we'd have no norepinephrine release, but we're enough of it that we're going to be dosing correctly. So reserpine is going to have a longer duration of action than the three other drugs, valbenazine, tetrabenazine, or deutetrabenazine. Another sympatholytic to keep in mind is metyrosine. Now, if we look at the name of the drug, you'll see that it has tyrosine in the name, which should tell you that it's almost directly related to tyrosine. And the difference is that it just has a simple methyl group coming off the side of it. And what metyrosine does is that it acts as a substrate for tyrosine hydroxylase. But unlike droxidopa, which is a substrate which and then turns into dopamine, metyrosine blocks and disables tyrosine hydroxylase. What this means is that we're going to be preventing tyrosine from creating all of its downstream effects. And so our overall effect is that we're going to be having less dopamine, less norepinephrine release. Same overall effects of preventing that norepinephrine, we're going to be decreasing that stimulation of the SA node. From me copying them. Decreasing the stimulation on the SA node, decreasing that heart rate and blood pressure. We're also going to be increasing the blood vessel diameter, decreasing the blood pressure. But what's important to know is that its indication is a little bit different. It's going to be for that pheochromocytoma. If you remember, pheochromocytoma is a tumor of the adrenal gland in which the adrenal gland produces too much of its norepinephrine and epinephrine. If I can go back here. And what's important to know is that the adrenal gland converts norepinephrine via this MPNT enzyme into regular old epinephrine. And that MPNT enzyme is only found in the adrenal medulla. And so the reason why we want to use metyrosine in this context is because the tumor is trying to produce as much epinephrine as it can. So by limiting the amount of norepinephrine that's available, we're going to be decreasing the amount of epinephrine as well. Any questions so far as we finish up this section? Cool. What we're going to jump into now is, does decrease epinephrine means decrease? No. The decrease, do you mean EP. Do you mean BP, blood pressure, or epinephrine? Epinephrine. Uh, because we're talking about a tumor that because the tumor is because the tumor is producing so much epinephrine, the that would technically be considered a a huge sympathetic nervous system stimulus. So by decreasing the epinephrine, it's we could say that we're increasing the parasympathetic stimulation, but it's kind of not considered that way because the tumor is artificially inflating the sympathetic stimulation. So normally decreasing epi means increasing the parasympathetic tone, meaning what the body seems like it's doing. So decreasing epinephrine increases parasympathetic tone, and then the reverse of that as well. But again, the tumor is kind of hyperinflating that response, so we wouldn't necessarily kind of make that equivalency. Cool. Our next section, we're going to be jumping into the parasympathetic uh, nervous system and kind of the drugs that have the biggest effect on it. Now, I wanted to put these slides, these green light slides, in at the beginning of every section as we continue because it's really, really big that you remember what what this table is, as well as the next one. You should be able to spit these ideas out at as if I called out to you on the street, you should be able to say these almost immediately. And as we go through it, this idea of what does the sympathetic nervous system if you activate the sympathetic nervous system, what does it cause? If you activate the parasympathetic nervous system, what does that cause? And these ideas are going to be becoming more and more drilled into you as we continue. And so the sooner that you're able to kind of ingrain these materials into your head, the sooner you're really going to grasp the material. Again, I just wanted to kind of re-explain muscarinic receptors because I don't think it's something I believe you guys went over this in patho. I can't remember. But remember that we have 5 different subtypes of muscarinic receptors, M1 through 5. In general, we can group M1, 3, and 5 as GQ GPCRs. They're GQ coupled. And M2 and M4 are GI coupled receptors. Because M2 and M4 are GI, we know that those would be inhibitory receptors. And those are going to be found mainly in the heart and the lungs. Ooh. And what's important to know is that the hyperpolarization of by activating these M2 and M4 receptors, we're going to be hyperpolarizing the SA node. And by doing that, we're going to be decreasing the overall response on the heart. And we're also going to be constricting the uh, the airway diameter and causing bronchoconstriction. So activation of M2 and M4 receptors really causes some pretty nasty things, right? We're decreasing the heart rate and we're causing bronchoconstriction. What's important to note too is that the M1, M3, and M5 receptors are GQ, which is excitatory. Now, I told you in our last session that whenever we think about GQ, we should always be thinking about smooth muscle, right? And the biggest effects we're going to see is meiosis in the eye. We're going to be seeing the contraction of the eye muscles, which is going to increase the pupillary diameter, which is going to make your eyes expand. And it's going to squeeze the smooth muscle surrounding the glands, which is going to, force them to release what's ever inside of them. So we're going to see the bladder release its urine. We're going to see the lungs, they're going to constrict and release some constrict, and we're going to release some mucus. Um, we're going to see the digestive tract increase its motility as the peristalsis increases. The salivary glands are going to become more watery. You're going to salivate more. And these ideas of squeezing the glands is going to be really important to keep in mind, because this is how we're going to uh, really see the biggest effects and the biggest side effects of these drugs. Again, just as a reminder of these different physiological structures, because it's important to know, is that there are two different kinds of muscles within the eye. We have the circular muscles and we have the radial muscles. And that when your eye is contracting in when your eye is becoming smaller in bright light, it's really the circular muscles via the parasympathetic nervous system that's having the biggest effect. Likewise, when there's dim light, we need to expand the pupil, which is going to be controlled mostly by these radial muscles. I think I said it. Yeah, circular muscles for closing the pupil, radial muscles for increasing the pupil, and that's going to be controlled by the sympathetic nervous system. Also important to note is we have the detrusor muscle, which surrounds the bladder. And this is the muscle that's uh, in charge of. And this is the muscle that's in charge of squeezing the urine out of the body when when it's ready to urinate. Also, another uh, another diagram of the eye, because we're going to be talking about glaucoma a lot. And I wanted to remind everyone what glaucoma was, is that we know our eye produces the aqueous humor, which flows from the posterior chamber through these suspensory ligaments past the lens into the anterior chamber. And in glaucoma, this outflow of the aqueous humor into the anterior chamber should be controlled. It should be allow an easy flow. But what happens is that in glaucoma, this output is not, or I think I have the next slide about it. Yeah, we'll talk about glaucoma in a second. What's important to note is that based on our ciliary muscle contraction, we can change the shape of the lens. And so when we contract the muscles, when the muscle contracts in the eye, that causes the lens to become rounder. And the more round the lens, the bigger the outflow the aqueous humor has when it tries to leave the posterior chamber. And so by contracting the smooth muscle, we're going to be allowing more, greater flow. And in glaucoma, what's important to note is that this backup the uh, of the aqueous humor is what causes major damage to the eye. Because as it accumulates here, it's going to push back on the lens, it's going to push back on the optic nerve, and it's going to cause major, major damage to someone's vision. As the aqueous humor flows past the lens, we're going to notice that there's two different kinds of glaucoma. One is open angle, meaning that it's able to flow, but this distance between the iris and the lens is really what's controlling its outflow. We also have narrow angle, or closed angle glaucoma, which is more to do with the structure of the eye, and you can't really affect what's going on because of the way the iris is covering the lens. What we know, like I said earlier, is that by contracting the lens, we're going to make it rounder. So we're going to be increasing this outflow. And what you can see here is that by contracting the lens and making it rounder, we're not really going to be able to change the flow of the aqueous humor here. It's still going to be pretty much the same as it was. So, which is why the glaucoma, open angle glaucoma, can be easily treated with different kinds of different kinds of ophthalmic drugs versus narrow angle. I believe is a medical emergency, and you have to go to the uh, into surgery in order to uh, clear the obstruction. So we're not going to have any drugs to treat narrow angle glaucoma. Any questions about glaucoma? Because it is a really, really big topic. All right. An overview of the parasympathetic nervous system drugs. We're going to have direct mimicking drugs, which are going to be our muscarinic agonists. We're going to have indirect drugs, which we should already recognize are VMAT inhibitors and our tyrosine hydroxylase. Remember, those were the sympatholytics. So a sympatholytic is the same as a parasympathetic mimetic. Um, and then a new one that we're going to come across is this acetylcholinesterase inhibitor. Likewise, we can have parasympathetic parasympathomimetics, which are going to be our what are called our anti-muscarinics or our muscarinic antagonists. So just a little roadmap.
Hello. Gabe, I actually have one question like related to glaucoma.
Mm-hmm.
So, is also angle closer the narrow angle glaucoma like related to fill of the water of the outflow, or what's the difference between the open angle and the angle closer?
Good question. So the difference between open angle and narrow angle or closed angle is it has to do with the outflow and the obstruction for the aqueous humor. Both of them relate to how easy is it for the essentially the water, the aqueous humor, to flow from the back of the eye to the front of the eye in this direction through here to the canal of Schlemm. The the difference between them is that in open angle, there is still a space between the iris and the lens. And we can make that space larger by contracting the ciliary muscle, which makes the lens narrow, makes it rounder, which allows a better outflow. In narrow angle, the reason why we can't do really anything with drugs is because no matter we can't get the eye to become round enough in order to make a gap between the iris and the lens. So both of them relate to this outflow of the aqueous humor because if it doesn't flow out, then it's going to put pressure backwards onto the optic nerve. The difference is in open angle, we can help the distance between the iris and the lens. In a narrow angle, we can't really do anything about it because of the way that the structure is. Does that answer your question?
Yes, thank you. Mhm.
Perfect. Cool. All right. Muscarinic agonists. 4 drugs: carbachol, bethanechol, pilocarpine, and cevimeline. Uh, very, very, very old drugs. Uh, you've probably seen them in the pharmacies. They're not tremendously given out a ton because we have better alternatives nowadays, but uh, they are where we're going to start, and they still have some use. Notice all of the same effects that we talked about here are the same ones that show up in the effects or the uses because we're going to be mimicking the parasympathetic nervous system. So we're going to be increasing rest and digest. And what does rest and digest mean? Well, it means you're going to be increasing the salivation. And what is that going to be used to treat? Is this uh, syndrome named after Sjogren's, or referred to as xerostomia. And xerostomia is when you have dry mouth. So if we want to increase the amount of salivation you have, then we increase the squeezing of the salivary glands, which is going to cause more of that watery secretion to enter into your mouth, and we're going to treat your xerostomia. Likewise, along this idea of what's it called, of rest and digest, increasing those glandular secretions is also going to increase the GI excretions, which is going to stimulate the GI system to increase movement, and it's going to treat your GI atony, or when your GI system isn't as doesn't have as much movement or as much stimulation as we would like, usually following something like surgery. So we can stimulate your GI system to kind of get started and keep working after being um, in disuse. Likewise, we can treat an underactive bladder by squeezing the detrusor muscle. And that detrusor muscle is going to push the bladder down through the bladder neck, through the urethra, and out of the body. More rest and digest. The other big effect here is that we're going to be causing meiosis in the eye. And meiosis is the contraction of the pupil. And what constricting the pupil is going to do is it's going to, should say, relax. Yes, we're going to relax the ciliary muscle, which is going to increase that gap between the lens and the iris, which is going to increase the aqueous humor to flow out from the back of the eye to the front of the eye through the canal of Schlemm and drain from the eye. And this is going to treat glaucoma. Now, which glaucoma is it going to treat? Well, it's only going to treat open angle, because closed angle refers more to the structure, and no matter how much we try to relax the eye muscles, we're never going to be able to create enough of an opening. Other effects to note, again, is that these are all mostly M1, M3, M5 parasympathetic stimulation, but we also get that M2 and M4. So we're going to be decreasing the heart rate, decreasing the contractility of the heart, and we're going to be decreasing the conduction velocity from the SA to the AV node. All this is going to have an effect of slowing down the heart, which is not useful if our patient has heart failure. If our patient is already having trouble using their heart to a degree that keeps them alive, then we wouldn't want to give them one of these drugs. Likewise, that stimulation of M2 and M4 is going to cause constriction of the bronchial muscle. That's going to cause bronchoconstriction, and this is never useful. It's doubly not useful for people who are asthmatic, right? They're already having trouble breathing, or if they have COPD. If you have trouble breathing, why would we ever give you a drug that makes it more difficult to breathe? Whoops. Very similar to the direct muscarinic agonist is the indirect acetylcholinesterase inhibitors. If we go back to our diagram here, here, when acetylcholine is released, I told you that it's broken down by the acetylcholinesterase within the synapse, and that's its main way of being broken down. And when you break down acetylcholine, you prevent the transmission of the cholinergic neuron. So if you inhibit acetylcholinesterase, then you would increase the shelf life or the duration of action of acetylcholine, which means that you're going to be increasing the parasympathetic tone. And so this is going to have the same effects as our direct muscarinic agonists. It's indirectly happening because we're not activating M1, M2, M3, M4, M5 directly with a drug. We're not getting a drug to stick to those specific muscarinic receptors. We're helping acetylcholine, the natural muscarinic neurotransmitter, by preventing its breakdown. And what you're going to notice is that there's uh, a general theme for the way that these drugs are named. We have the stigmines or the euphoniums. So neostigmine, physostigmine, pyridostigmine, and then we have ambinonium, edrophonium. And then lastly, we have malathione, which is an irreversible acetylcholinesterase inhibitor. Same effects. We're going to be increasing glandular secretions, we're going to be relaxing the ciliary muscle, and we're going to be squeezing the bladder. Same things here. It's not useful to decrease heart rate, decrease the ability for the heart to contract and to hold a stimulus from the SA to the AV node. So it's not going to be useful for heart failure, and it's never going to be useful to cause that bronchoconstriction. As we think about this, we can think about what the side effects would be, right? Because side effects can be either from its effect somewhere else or its over effect in the places we want it, right? So we can have incontinence, the inability to control your urine, by having an over relaxed detrusor muscle. So what this is going to do is it's going to allow the urine to leave essentially when it wants, and we're going to make it. We can make it hard for the person to control when they urinate. Likewise, we can have also production because we're going to be stimulating the stomach to produce more acid, which can degrade that mucous membrane within the stomach, which can, it can wear down the stomach lining, and then we cause an ulcer. Likewise, you can have excessive salivation, which can be annoying for the person. And our contraindications are disease states in which we would never want to prescribe these drugs. And obviously, we'd never want to prescribe it with closed angle glaucoma because, again, what are we going to be doing? We're going to be increasing production of different excretions, right? So we're going to be increasing aqueous humor production. But in open angle glaucoma, that's fine. It can drain even if we make more. But in closed angle, we're going to be making more, but it's never going to be able to drain. So we're going to be causing a bigger effect, and we're going to be causing blindness eventually. Likewise, that bronchoconstriction from asthma is going to make it harder for the bronchoconstriction from our parasympathomimetics is going to make it harder to breathe. So we'd never give it to someone with asthma. Likewise, our precautions are disease states in which we can monitor for what's going on. COPD, bronchitis, places where you would have trouble breathing. If you have a predisposition for cholelithiasis, which is the production of gallbladder stones, if you increase the gallbladder secretions, you're more likely to make gallstones. So we want to be careful in patients where gallstone production is known. Likewise, biliary tract disease is very similar. You're going to be creating more of the same gallbladder secretions, so avoiding those gallstones. Antimuscarinics. Oh boy, look at that list, right? Welcome to pharmacology. Big, big lists of drugs. All right. And yes, you would have to memorize all of these for the exam, including the brand names. When we think about the antimuscarinics, we can think about the opposite effects of the muscarinic and agonists, right? We're going to be constricting the ciliary muscle. So what that's going to do is it's going to cause the pupil to open up. That word that we're going to use to describe the pupil dilating is mydriasis. So miosis for constricting the pupil, mydriasis for opening the pupil. And this is useful for when we want a retinal exam. So for those of you who have gone to the optometrist, they put those drops in your eye, causing your eye to open. This is they're using an antimuscarinic. Likewise, if we want to decrease sweating or decrease the mucosal secretions, say in the stomach, then using an antimuscarinic is useful because we're going to be decreasing all those glandular secretions. We can treat an overactive bladder by decreasing the bladder contraction of the detrusor muscle by relaxing it. And then, likewise, we can cause bronchodilation by preventing the stimulation of those M2, M4 subtype receptors, which is going to open up the airways and make it easier to breathe. Which you might recognize some of these drugs, the ipratropium, the tiotropium. These are inhalers. You might recognize oxybutynin for for urine, the solifenacin, darafenacin. Other big effects is that we're going to be preventing the stimulation of M2, M4, which is going to allow the heart rate to increase. And this is not useful for heart failure. Again, we don't want to be increasing, just like how we don't want to be, decreasing the heart rate. We don't want to be messing with the heart, making it slow down. We definitely don't want to make it speed up because that's just going to make it harder for the heart to keep up, and it could induce a heart attack. Side effects of antimuscarinic should be fairly straightforward, thinking about what an over effect of them would be, right? We're decreasing secretion, so we're going to get dry mouth. That's xerostomia, the thing that we would treat with a muscarinic agonist. Dry skin, hyperthermia, because we're going to be decreasing sweating, so we're going to have less ability to regulate temperature. Tachycardia, which is, again, we don't want to be using in our tachyarrhythmias or our risk of a heart attack. GERD, because we're going to be relaxing the gastroesophageal sphincter, which we would normally think, oh, great, we're going to be, we're going to be increasing stomach acid production, but that's fine. That can we're not going to be increasing stomach acid production, right? Because we're decreasing those secretions. But by relaxing the sphincter, that's going to allow for the stomach acid to wash up into the esophagus and cause it to burn. Obstipation, urinary retention, flush, all big effects of decreasing that smooth muscle tone. And then, of course, the mydriasis is a side effect of taking the drug. So you'd have blurry vision because now you can't focus your eye in bright light. Any questions from these? Very nice. Quickly, I just want to kind of go into these more in-depth ideas about the muscarinic receptors because I think it's important to be able to talk about them in an in-depth way. Again, we know that it's the M1, M3, and M5 that innervate smooth muscle in the lungs, the GI tract, the bladder, the eye. I should also put there, all the glands, the salivary glands, the sweat glands, everywhere in your body, really. And remember that these are GQ coupled receptors. So we're going to be activating phospholipase, which is going to create this IP3. IP3 increases the calcium in the receptor, which is going to cause that muscle contraction. By activating M1, M3, M5, we're increasing parasympathetic tone. By deactivating it, we're causing less parasympathetic tone. All right. M2, M4, big effects on the SA node. What I didn't put here, what should be here is uh, smooth muscle around the lungs. And because they're GI coupled receptors, they're going to be decreasing CAMP, which is going to decrease the activity of PKA. And again, if you activate M2, M4, even though it's GI linked, you're still increasing the parasympathetic tone. So don't get these confused. Is just because one's excitatory, the other's inhibitory. If you're activating them, you're causing more parasympathetic tone. So this question is, well, how do antimuscarinics cause vasodilation, right? And it's kind of an interesting mechanism because what's important to know here is that the blood vessels of the smooth muscles do not dilate by themselves. They're stimulated by the surrounding endothelial cells. So it's the endothelial cells, if this is your blood vessel, then your endothelial cells are here. They're surrounding the blood vessel like a cone. And it's these endothelial cells that, sorry, let me back up. It's these endothelial cells that make up your blood vessel, right? And surrounding the endothelial cells is the smooth muscle. So, in order for our drug, which is floating in our blood, to get to the smooth muscle, it has to diffuse through the endothelial cell, its effect. Now, it would be really, really nice if it could just go directly through like this, but what's actually going to happen is that it's going to affect a receptor on the surface of the endothelial cell, which is going to carry that response through the endothelial cell onto the smooth muscle cell. So let's take a look at that. Here's our blood up here, and our drug comes in and affects our receptor. This is a GQ coupled receptor, and as we know, GQ is related to smooth muscle contraction. GQ is going to increase the amount of intracellular calcium, and that's going to stimulate this nitric oxide synthase enzyme to cleave arginine into nitric oxide. This nitric oxide diffuses into the smooth muscle cell, where it's going to stimulate another enzyme called guanylate cyclase. This guanylate cyclase is going to convert GTP into cGMP, which is essentially it's like CAMP, CAMP, which is then going to stimulate protein kinase G, which is going to cause vasodilation. All right. So big point here to kind of get across is that our drugs don't have a direct effect on smooth muscle relaxation.
Could you actually repeat the drawings that you drew?
Mm-hmm.
The skin, and then I wonder why like GS is not on here with the muscarinic receptors.
Good question. So what this is showing, let me back up a little, is that here we have our blood, which is flowing through here. Blood, 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 blood. And in here is going to be our drug, right? This is where our drug is going to come through. Now, what we want as our ultimate effect is our drug to contract the smooth muscle surrounding the blood vessel. Because if we look at the blood vessel from the side, it's this smooth muscle which is surrounding the blood vessel that will cause it to contract or relax. And so what happens is that our drug will come in and it will bind to the muscarinic receptor, which its downstream effect is that it produces this nitric oxide, which then stimulates the smooth muscle. So the question is, how do these antimuscarinics cause vasodilation? And through uh, it's through this GQ coupled receptor, through this downstream effect of nitric oxide. Nitric oxide being a major uh, reason for vasodilation, which I believe we get to later in this semester. I'm not sure. I have to double check when we get to like nitroglycerin. The question is, why doesn't GS show up? And the short answer is that just because how Mother Nature wanted it to happen. But if we think about uh, what happens here is that think about what the effects are, right? Is that we want muscle contraction to cause the glands to excrete their products, right? Because we don't want the glands to really produce more of something. We just want them to have an easier time releasing it. And so this is why it's a GQ coupled receptor, right? Because we want that muscle contraction. The same way here is that the reason why it's GI linked instead of GS is, truth be told, I don't have a major reason, but I believe it's because we don't really want to stimulate the uh, we want to control the heart by slowing it down. We don't really want to control the heart um, by speeding it up. I believe. Um, no. Uh, Let me think on it actually, because I think he went over it in class. I think someone asked that as well, but I believe his response was "It's just the way that it is." But let me come up with a better answer before I dive into that. So that one's on me. Um, cool. Any other questions about how the parasympathetic nervous system works before we dive into this? Cool. There is one other drug that uh, we should talk about in its usefulness with these acetylcholinesterase inhibitors. And that drug, I couldn't find a good diagram for it, but that drug is called pralidoxime. Its brand name is 2PAM, and it's a acetylcholinesterase reactivator. And the reason why this drug was developed, let's put this on a new page because this is something big we can talk about. The reason why this drug was uh, created was because there is a major adverse effect related to too much acetylcholine. So when you have uh, too much uh, what am I trying to say? When you have too much acetylcholine stimulation, this can lead to a very, very serious condition called cholinergic crisis. Now, sorry, I just want to make sure I get this right. What's important to know about this situation is that this is indicative of having too much acetylcholinesterase inhibitor. When you have too much of the acetylcholinesterase inhibitor, that's going to skyrocket the amount of acetylcholine in the body, right? If you block the thing that breaks down acetylcholine, you're going to increase the amount of acetylcholine in the body, and that's going to cause too much at that receptor. And this leads to this cholinergic crisis in an interesting way. Because while we can use drugs like pyridostigmine and pyridostigmine, uh, now I'm forgetting them off the top of my head, the neostigmine, the ambinonium. Well, we can use these to increase our acetylcholine. One of the big uses for them that we're going to see is to cause a paresthesis. I just want to make sure I get this right. Sorry, not paresthesis. My bad. Paralysis. And let's think about why that's happening, right? If you administer acetylcholinesterase inhibitor, you're going to be increasing the amount of acetylcholine, and that's going to be happening on this somatic muscle, right? And what that's going to do is it's going to constantly lock your muscles into contraction, and you will not be able to release them. So your muscles are completely locked up, hyperstimulated, hypercontracted. So when your muscles are so depolarized that they can't repolarize, this usefulness of the paralysis can be used in multiple settings. And the biggest one is uh, when we talk about intubation, is that we can administer acetylcholinesterase inhibitor when we're intubating someone. So that way they're, am I saying this correctly? Nope. Whoops, not intubation. I don't think we use it for anything. I think it's just my bad. I'm skipping ahead. This paralysis is indicative of too much depolarization of the somatic pathway, of the skeletal muscle. So, because these nerves cannot repolarize, what's important to note here is that this is similar to another condition called myasthenia gravis. Myasthenia gravis is an autoimmune immune disease where the body destroys the nicotinic receptors on the skeletal muscle. And so by destroying the nicotinic receptors, we're going to be decreasing the transmission of cholinergic stimulation. And so we're going to have poor muscle movements. They're going to be very weak. Uh, oh, I jumped the gun on that. Okay. And so what we can do, I just want to make sure I get this right, is we can use ambinonium to test for uh, this myasthenia gravis. Because what ambinonium, why it's ambinonium, I think it's just because that's what it was known for, is that if you administer ambinonium to the patient, and they have a huge increase in acetylcholine, one that could cause somewhere around paralysis, well, that's indicative that the person has a normal level of acetylcholine normally, and that by blocking acetylcholinesterase, we're going to be skyrocketing the acetylcholine and causing paralysis. Versus if you administer ambinonium to someone with myasthenia gravis, we're going to be increasing the amount of acetylcholine that's available, which means that relatively we're going to see normal levels of stimulation of the nicotinic receptors. So if you administer ambinonium to someone with myasthenia gravis, we won't see as much of a locking up effect because they'll have less uh, nicotinic receptors for us to lock up our acetylcholine to. So once again, we administer ambinonium to someone with myasthenia gravis, and what we're going to see is that we're going to be increasing the acetylcholine, but because their immune system has destroyed so many of those nicotinic receptors, we're not going to see a huge paralysis effect. It's kind of like if you throw a whole bunch more kids at some slides at a water park, if you get rid of a bunch of slides, you can't send down more kids. So we can only cause so much effect on the muscles. And so this is the ambinonium test, is that this is how we can test for myasthenia gravis. The big effect of having too much acetylcholine, like I said, is that it can lead to this condition called cholinergic crisis, which is a major, major, major emergency situation in which there's too much acetylcholine inside the body. And so we can test for this cholinergic crisis using a different drug called tensilon, which is edrophonium. And so if you administer edrophonium, which you remember is one of your uh, acetylcholinesterase inhibitors, if you administer edrophonium, this is going to have no effect on the person, right? They're not going to get any worse or better. They're still going to have this huge amount of acetylcholine. So what is that going to look like? Well, you're going to have lots of bradycardia, hypotension, your GI tract. While we're talking about more parasympathetic stimulation, so we're going to be talking about increased salivation, increased urination. What's going to happen to your eye? Well, your eye is going to be constricting. We're going to have ataxia, meaning your movements are wild. You can't really control your muscle movements, anxiety. And then with your musculoskeletal system, we're going to have obviously the weakness. We're going to have spasms and paralysis. So if you administer edrophonium and you have no change in these symptoms, it means that you're already blocking this acetylcholinesterase. And so, uh, uh, sorry, by administering edrophonium, you're already blocking this acetylcholinesterase. So you're not going to see any change in this. Versus if the person is not in a cholinergic crisis, if they're not blocking that acetylcholinesterase, then we would start to see those symptoms, right? Because we've induced an effect. And so this is a way of testing for it. And uh, you know, the question is, what causes this cholinergic crisis, like out and about? Well, it would be from overdosing on your cholinesterase inhibitor, right? You took too much. Oh, I took 3 of them when I meant to take one, or I wanted to kill myself, so I took my whole bottle. The other the other portion that we see it from is from organophosphates. And this is from farming. And so a big test that you'd see in the Midwest is you'd administer edrophonium, the tensilon, to someone who's been working on a field, and you can tell if they're being poisoned by organophosphates. And so now that we've tested for the cholinergic crisis and we found it, the question is, well, how do we stop it? Well, we administer a muscarinic antagonist. So our atropine, our pralidoxime, um, we'll get back to pralidoxime in a second. But our muscarinic antagonist is going to block our muscarinic receptor from being stimulated by our acetylcholine. Likewise, this pralidoxime is going to reactivate the acetylcholine, which is going to decrease the amount of it's going to reactivate acetylcholinesterase, which is going to decrease the amount of acetylcholine in the synapse. And we're going to take our farmer away from being poisoned from this cholinergic crisis. So it's a way of managing it. It's an antidote. Any questions about this cholinergic crisis and this kind of special case that's going on? All right. I believe that is all the content that we have for this session. Do let me know which you guys preferred, this drawing or the more of the PowerPoint format. I wanted to try out both again. Um, and going forward, depending on what people like, we'll just use one or the other.
I
Um,
actually like the drawings more.
Drawings,
Mhm.
sure. Um, how's the content like just being listed out here and then drawing on top of that? If I could draw on these margins, I wish I could do that.
It is very tough.
Yeah.
And I guess I will rewatch the recordings since it was like, I think I was like, I need to
put more effort on to understand.
It's uh it's a lot of information that we went through. And the big thing to note here is that this is just an exposure to what's going on, right? That will I'll send you guys, if people want, I can send practice problems to kind of help think about the drugs. But the big thing to know here is that the when you take the class for real, it's going to be one, it's going to be a slower pace. Um, but two is that he's going to spend more time kind of how can I say this? He'll spend a lot more time working with and kind of repeating himself. The well, how do I want to put this? The thing with the pharmacology is that when you go through it, all he does is show a picture and he kind of like draws a little bit, but he doesn't really do anything. Kind of writes random vocab words on the thing, but we'll go through. Depending on, I'll as people watch the lecture, I'm gonna send an email out, and if people want us to do a review on Thursday of the drugs, we can do a review of what we've gone over so far, or we can go on to the next part. Um, Depending on what people want, I'm happy to slow down or speed up as we need, and it should be fun. Um, Hopefully, was this all new information for people? Like I wasn't repeating myself from Patho. Good, good, good. All right. Uh, Let me find that question to the GS coupled, and I think we are all set for today. All right. I will see you guys later.
Thank you.
Uh, Recording is going to go up on YouTube. I'm going to sit down and work on getting it up tonight. It'll be good. All right. I will see you guys.